Hello, everybody. I want to welcome you to Pediatric Grand Rounds. I'm delighted today to introduce our speaker, Dr. Erica Pan, who is the Director and State Public Health Officer for the California Department of Public Health, which is a role that she assumed in February of last year. Dr. Pan is a pediatric infectious disease specialist who actually, I learned today, did her residency and pediatric ID fellowship here at UCSF before going on to other roles. And now she's back visiting with us, and we're delighted to invite her back. She spent most of her career leading public health efforts at the local and state levels, including as California state epidemiologist and leadership roles at the Alameda County and San Francisco Departments of Public Health. And today, Dr. Pan will show us how California is reimagining public health partnerships to strengthen outbreak response and help clinicians stay connected to the latest guidance. And she'll share practical ways we can engage more directly with public health initiatives. So please join me in welcoming Dr. Pan.
Thank you very much, Dr. Hirsch. Sounds like you can hear me okay. Well, thank you. Thanks for welcoming me back. I have been seeing my ID colleagues, and really nice to actually physically be here. I miss my time seeing patients both through the UCSF main campus and when I was at Oakland Children's. So hoping to one of these days get back, but I'm worried it's getting too far out. So yes, as mentioned, today I'm going to talk to you just a little bit about public health perspective on children's health. And thanks again to Devin for inviting me. I'm going to start actually with something that I will acknowledge is a little bit out of my personal realm of expertise, but what I'm learning a lot about, as are all of us, around just thinking about our new world and digital and social media impacts on children, and a little bit of what we've been doing at the state level there and how we think about it from a systems and policy level. And then, of course, top of mind for many of us in medicine, pediatrics, infectious diseases, and public health over the last year and a half has been the turmoil of vaccine recommendations. So I wanted to make sure you are all clear on where to look for what is required in California and what is required to be reimbursed, and how we are making those decisions. And then, of course, measles is also a big, important topic right now, just as far as what we're seeing globally, nationally, and certainly here in California. And then, yes, I'd love to talk a little bit more about what we're doing as we reimagine in public health and thinking more broadly about our partnerships. I think this has been mentioned in a couple different ways, but I hope again that you'll be able to figure out exactly where and to look and know what is California recommending as far as the state health department, and who are we looking to and aligning with. I also want you to be able to find up-to-date information and know about what's happening with measles in California and elsewhere. And then, yes, learning more about our FACT Coalition and other partnerships. So shifting and talking a little bit about mental health. And again, I think one thing I'll just pause and say too, and actually I'll go to this slide as well too, is as a pediatrician in public health, I do have a bias and think that, and there are many pediatricians who actually go in the public health direction, whether it's completely or still bridging their clinical work. But I think already as clinicians, we have to think about the environment our patient is in. They don't have autonomy to make their own decisions. And in general, in public health, that is the way we think about what is impacting our patient. And it isn't just the patient in front of us or whether or not they will, take that medication I'm prescribing, but really thinking about their family environment. What is happening there? Who's taking care of them? What is their environment like? Is it safe to walk outside? Is there any other domestic violence, other trauma? We've all made a lot of progress thinking about ACEs moving forward. And then what is the community environment like? Again, are there safe green spaces? Are there food deserts or not? Do they have access to healthy food? What are the relationships? What education environment do they have access to? What is their faith community? What are the other environmental pressures in their community? And then the environment in general, right? We all know that place matters as far as life expectancy, thinking about urban sort of, the big example I gave at our State of Public Health report was thinking about Compton, LA versus oh gosh, now I'm blanking on the other highly resourced area, but there's a 17-year gap in life expectancy depending on where you grow up. So your environment is incredibly important. And as we think about climate change and the environment and air pollutants, we know, and actually the latest thing with that is data centers. They are put into places that are impacting family and children's health, and often the most under-resourced who don't have advocates for them. And then that then gets us to society and policy, and that is where I really enjoy being able to work across different departments and agencies to think about health and all policies, and what are some of the other social and economic factors that are influencing the social determinants of health. So that, of course, all helps us think about how we approach mental health as well. And so wanting to share a little bit, there's a bill that was passed a year or two ago where we are starting to put together kind of what we understand with our teams at CDPH, what's happening with social media use and what are the sort of downsides and what are the benefits. So just again, some of you may have seen this data, but thinking about how much, and just those of you who are parents also, I'm sure, are thinking about this even more, depending on the age of your child. But 27% of teens and over a third of young adults report almost constant social media use. So, we used to worry about almost constant watching TV, and now we have a whole nother thing that's portable and swipeable with the dopa surges, and so seeing that increase over time. And we know, I mean, you all know this, but I think as we kind of educate sort of others around us during our teen years, those neural systems are supporting aspects of social media use. So that really impacts your social reward processing, your emotion-based processing, your emotional regulation, and how you mentally sort of process things and take in the world around you. And these are underdeveloped and so are incredibly impacted by this constant use of a different media that we're all learning about. So what are some of the impacts we do know about? There's a small but significant association between social media use and depressive and anxiety symptoms. We also know, and I'm sure you've heard a lot about this through various traditional media covering it and lawsuits, but engagement with or exposure to image-related social media content is linked to body dissatisfaction and dieting or overeating. And nearly half of US teens report cyberbullying. So victims of cyberbullying have higher suicide-related and depression risks. And frequent social media among adolescents is associated with other healthy risk behaviors. So sexual risk taking, gambling, substance use. On the flip side, there are benefits as well. Social media can support identity development for youth. It's a way they can self-express and get feedback, especially in certain populations and especially in more rural populations where, for example, LGBTQ youth might be able to find people that do support them, even if their immediate environment is not doing that, or other, finding others like them that they can relate to, perhaps if they can't find that in their own physical community. And it, of course, provides access to a lot of educational content and peer learning, again, especially for rural youth with other limited resources. Also allows neurodiverse youth a manageable way to socially connect. There are many, as we know, we had a lot of downsides of learning during the pandemic virtually, and there were a few sort of kids that actually thrived in that environment and then did because of the way that was working for them to learn and interact differently. So how many of you by any chance know Dr. Sohail Sood from UCSF? A few at least. So he has been an amazing person. We recruited him during the pandemic to lead our school health COVID work. And then after that, we briefly had him in our department doing some chronic disease work. And then then he was quickly swooped to lead our children and youth behavioral health initiative that is sitting at our Cal Health and Human Services agency level. And this has been a great initiative that has been cross-department, across public health, the behavioral health teams of the Department of Healthcare Services, and many other partners to really try to transform the way we're looking at supporting youth and families. So again, I'm speaking to you all here in the healthcare setting, but as you think about all the other settings that your patients are in, being able to not only expand the behavioral health workforce, I know many of you who are seeing primary care patients are probably constantly needing more behavioral health support, needing more places to refer your patients to. So increasing access to that, and especially again, specifically for youth and culturally appropriate for youth. and supporting non-specialist healthcare providers. There's a whole workforce initiative too that's happening with the Behavioral Health Services Act, trying to increase the pipeline of behavioral health specialists. And then, of course, in the school setting and the childcare setting, bringing wellness into the classroom and nurturing a supportive campus culture and expanding access to school-linked care services. And there's been more work as well trying to get reimbursement for school-linked care services through, for example, Medi-Cal. And then the pros and cons again of social media, you can bring some behavioral health resources online and prepare that for the next generation of digital support. So there's been a lot of linkage to care through digital work and some telehealth resources that have been developed with this CYBHI initiative. And then, of course, trying to work on these upstream issues about community resilience, building a community-based workforce. So these are all some high-level settings and strategies that CYBHI has done over the last 3 years. I also acknowledge, and you can see it's a little hard to see at the bottom, but there's a cross-departmental, a lot of different partners have been working on this together. A lot of that work is sunsetting, and then some of it's transitioning into other work through the Behavioral Services Act, again, across public health, Department of Healthcare Services, and other community-based organizations. So some of the outcomes, they're just coming out with a report from the work that's been happening over the last 3 years. And at least based on one survey of some high school students, they have seen decreased suicide attempts in the past, students reporting suicide attempts in the past 12 months, and that has decreased 50% from a peak. The other thing I'll just mention is it's really striking when I recently did our State of Public Health report and looking at what are the drivers of causes of death in the youth and young adults, and suicide and overdoses are some of the leading causes, and where we're seeing the increasing rather than decreasing death rates are in adults, but young adults as well, as far as suicides and overdoses. So this is something we want to intervene in earlier and sooner as far as community resilience. So there's also some new resources that CYBHI has for healthcare providers, and there are links on this website here too. So just wanted to make sure you're all aware of some of those efforts. And again, thinking about this sort of from a public health lens, how we think about sort of the individual all the way out to environment and community. So I'm going to switch gears to something I've always been very passionate about, and glad to be in the state and the place I'm in to help really champion vaccines and immunizations, because as you all know, they are under threat. So this is just a little reminder or primer on, how do vaccines get sort of approved and all the way to recommended and then reimbursed and access. So there's this pathway of clinical trials, of course, or there's, especially over time after vaccines have been approved and released, there's post-clinical trials, real-world data that we can look at. And then the FDA has a vaccine, I'm going to mess up the acronym as far as it's something biologics, but the VRBPAC committee determines whether a vaccine is safe and effective. So they bring together their advisory committee that is cross-sector with different vaccine and science and immunology specialists. The manufacturers will bring their data, the CDC and the FDA and others will be looking at different levels of data to, again, determine is this vaccine safe and effective and in which populations. So the FDA will then typically approve or amend that licensure. And then typically ACIP, the Advisory Committee on Immunization Practices, which is also a cross-sector advisory group to the CDC that typically, again, has a broad depth of immunologists, scientists, clinicians, public health specialists, and liaisons from several professional organizations, including AAP, many of my sort of public health agency counterparts, as far as the state and territorial health officials, Council of State and Territorial Epidemiologists, all have liaisons to the Advisory Committee on Immunization Practices. And as you all likely know, because we look to that for what are the latest recommendations on vaccines, they do a really deep dive. They have subgroups that work for years and months on looking at the data post FDA, trying to make recommendations for what, and looking at benefits and risks and making recommendations for population-based recommendations. As you also know, that was replaced in June of last year. The current secretary fired all 17 of those members, including our immunization branch chief, who had just joined. He'd been on many work groups before, but he had briefly been part of the ACIP membership. So that was replaced. And then typically, just to talk through the process some more too. Typically, the CDC director approves that guidance. That typically happens relatively quickly. And then insurance will determine coverage. And the Affordable Care Act actually points to ACIP as what insurers in the United States are required to cover. So it's been a long tradition of using this information, this committee that again has had a lot of vetting for conflicts of interest. They have public meetings where there's public comment. There are advocates on those committees as well, and had long-standing been a practice of how we determined what vaccines are recommended and all the rigorous data and evaluation that happened behind that. And then trying to get from there to distribution and access, which then gets into many of your hands as far as making sure there's availability at the right clinic times, the right providers, and that children and adults have access as far as insurance. So there are many places in this regulatory pathway that have been disrupted over the last year and a half. So the first one was this June 2025. I'm not going to walk through all of them, but it has been a roller coaster. There was just something in my inbox as I was heading over here. I haven't read yet, but there was an executive order last week or a few weeks ago trying to go back to what the secretary had also declared and the acting CDC director signed off on, sort of going back to the Denmark vaccine recommendations rather than what we've been doing in the United States for years. As you also may know, there's a lawsuit with the American Academy of Pediatrics and multiple other organizations against the secretary for removing these committee members and not bringing back qualified, competent individuals. So there are just so many disruptions. And then, and even in the upstream here in the FDA, they did allow mRNA flu vaccine to be presented, I believe, yesterday or today. So, but there, as you likely have heard as well, a lot of funding pulled from mRNA research that has been really groundbreaking. And it's been unclear what will be approved from the FDA for many different vaccines. So what are we doing about that? And what are we doing about it in California? Last fall, when all this was evolving, in August as well, just back to that visual where the CDC director typically approves things. Well, the one CDC director they had for a minute, she was the first Senate confirmed. Her name was Dr. Susan Monarez. When she was asked to just sign off on vaccine recommendations that were not evidence-based and not consulting the subject matter experts within the CDC, she was fired. So there was just a lot of chaos continuing to happen. And we were very, very concerned in the state of California and across many states about what would happen as far as ACIP being the point of reference for many things that we do. So thankfully, our team had been seeing a lot of the concerns about this for the months prior and had started to look at all the different places in California statute where we refer to the ACIP as far as, again, recommendations, what is needed to be reimbursed by California regulated insurers, and also even scope of practice. What can pharmacists provide without a prescription? And then also some liability protection had been in prior statutes as well, but pointing to the ACIP. So what we were able to do, it was all at the very end of the legislative session and a huge heroic work from our immunization team, a lot of lawyers working very closely on drafting, proposed different language to remove ACIP from those statutes and instead allow the California Department of Public Health to make different recommendations as the source for immunization. So instead of ACIP, and then there's also been a lot of concerns and threats that haven't quite come to fruition yet, although the U.S. Preventive Services Task Force has not convened since Secretary Kennedy has been in place. So we were able to sort of freeze recommendations as of January 1st, 2025 in this statute, and then anything new or updated would be by recommendation from the California Department of Public Health. But we also put in there, and in general and principle, that we would still be looking to national medical professional organizations or other trusted evidence-based organizations. So we typically continue to tie to AAP, that's the biggest one most relevant to all of you, but also other professional medical organizations. So that was a huge win for us. Related to that as well, and I'll talk a little bit more about the West Coast Health Alliance, but we are working with Hawaii, Washington, Oregon, and ourselves to make sure that we are looking together at what is out there, where there are threats to vaccine recommendations, and where are the reliable sources. So we, in alignment with our other 3 states, continue to point to the American Academy of Pediatrics, which thankfully had actually started doing vaccine recommendations before the ACIP was ever created. And this is the first time in history that there's been such a divergence of recommendations from AAP and ACIP, but thankfully AAP has a lot of the infrastructure that a lot of other medical professional organizations don't. So we should be really proud of our pediatric community as far as that goes, but want you to know that we continue to point to the AAP for pediatric recommendations. And then where do you go for up-to-date information on in California? What are we still recommending? What's still required by insurers? We now have a Public Health for All website, and that is where we will post any updates. It's part of that statute in AB 144 that we will post on there, and then we'll go also into sort of a printing and filing of the recommendations, so that again, insurers in California have to cover what we are recommending. And again, we will, in these postings, we will show you where we're pointing to and where we're basing our recommendations on. The other nice thing as far as insurers is the American Health Insurance Association, AHIP, has also put forward statements both last year and then the beginning of last year and then again in September of 2025, saying that they will continue to recommend and support the reimbursement of sort of vaccines based on prior schedules through the end of 2027. Not all insurers are part of that professional organization, but a huge majority, and certainly the biggest ones are. So shifting gears a bit to measles. So we have seen again over the last couple of years more cases than we're basically back to levels we had seen in the late sort of 80s, early 90s is when we had huge outbreaks in the United States. And that's actually when the second booster for MMR was recommended. And then we saw huge decreases again. And then, as you all know, we declared measles eliminated in the US in the year 2000. And that was really what that means when we're saying it's eliminated. It means we don't have local transmission. Any measles is imported into our sort of country from other places. And then we work in public health with all of you as our healthcare partners to sort of control once we have cases. So over 2,000 cases to date already in this year. So we're going to be likely over doubling what we saw last year in 2025. And really importantly, over 125 hospitalizations. Again, not surprisingly, but over 90% have not been vaccinated. And the vast majority are pediatric patients or younger than 20 years of age. Most of these cases are concentrated in just a few states. So you can see sort of you heard about the big outbreak in Texas last year, and then South Carolina has had a big outbreak. And then Utah is the most recent one, which is, of course, closer to our borders. And it does seem like the South Carolina outbreak is slowing down, but Utah is still very active. And then another way to just look at over the last sort of 25 years, where have the big outbreaks been? You can see sort of when you see more than 50 cases, those are kind of those bigger outbreaks. And those are always in largely unvaccinated communities. The last time we had a big outbreak like that, many of us remember, was the 2014-2015 measles outbreak. And that had over 140 cases related to it, most of them in California, but many all over the country as well. So again, just sort of thinking about, well, what are the risks? And as we see this increase globally, the outbreak risk here in the United States is based on a couple major factors. So what are the disease rates abroad? And we do know those are increasing because post-pandemic, there was disrupted access to vaccines, and then also, unfortunately, globally decreased confidence in vaccines as well. So there's, as there's more measles outside our country, there's of course more likelihood of importation via travel. And then, really importantly, when it is imported, what kind of community is it entering? Is it a community that is largely unvaccinated, or do you have herd immunity in that community? So what is it looking like here in California? So we, as of last week, had 49 confirmed cases. Again, patterns are similar to the United States. So we're seeing the vast majority in under 20 years of age, 3 hospitalizations, and again, largely unvaccinated populations. 3 of have been related to smaller outbreaks. Placer, Sacramento was the most recent, Riverside, and Shasta. All of those clusters were still relatively small compared to what you're seeing in other states. And all of them were related to either international travel to countries where they're seeing larger outbreaks, or there was at least one of these outbreaks that was fueled by travel to, now I can't remember if it was South Carolina or Texas, but to where there was some other large outbreaks happening. And then you can see sort of where in the state we've had measles. And here's what our patterns are as far as our contribution to measles nationally. So 12%, this long bar here is about, California is about 12% of the US population. So this is trying to show our contribution to measles cases and what percent of US measles cases are from California. So the Disneyland outbreak, we were definitely sort of a source or the sort of ground zero for that. And that's when we last had the biggest number of measles cases and contribution nationally. But you can see over time, actually, we are, much lower than our sort of population representation in the country. And this is largely due to, if you look again back to which communities are you coming back into if you import disease, and what are the vaccination rates in those areas. So we are still thankfully over 95% as far as our kindergartners with 2 MMR doses. And I'll show you the trends in that in a moment. And you can see and if you look at this graphic from the period before this, there's a lot more of the dark orange of less than 90%. So a lot more and more states are getting to below 90% herd immunity in their states. And there's been a lot of threats to vaccine requirements in schools in legislation over the last couple of years, especially in post-pandemic. Not many of them have passed, though. I was just also in a recent call. They were presenting to us. Many have been proposed, but there have been very few that have actually passed to reduce school vaccine requirements, despite the state of Florida saying, the Surgeon General there saying that they wanted to stop requiring vaccines in schools. That has to actually pass through legislation. So another way of looking at this is we did have some lower dips in the early 2010s. And then some of you also may remember we had stronger vaccine legislation that was passed over that time where we got rid of personal belief exemptions, and that really helped improve our rates. And then for a little while, we were seeing a lot more suspicious personal medical exemptions. And then we also passed some legislation thanks to my namesake, but not related. Everyone always asks. Dr. Richard Pan is also a pediatrician running for Congress now, which is great, who's been a really great champion for immunizations and helped pass both of those laws actually around strengthening our vaccine requirements and really cracking down on medical exemptions that I remember seeing at the time were like hyperbaric doctors who give Botox, charging patients $150 for medical exemptions. So we're steady above 95%. But as you can see, even in California, we are skirting with getting below herd immunity. So that is where all of us and a lot of different partners need to continue to rally together to work on vaccine confidence and vaccine access. I'm sorry. So what are some quick top things to know about measles? So febrile rash illness, keep in mind sort of the 3 C's around cough, coryza, and conjunctivitis. In 2 to 3 days, they can typically develop Koplik spots, so those white spots in the inner buccal mucosa, and high fevers. And then 3 to 5 days later, a red maculopapular rash that really does, for whatever reason, tend to descend from the scalp down to face hairline downward. I don't think anyone's ever figured out why that is. It's sort of like jaundice and measles. The other really important thing to know that we don't have on this slide is that people are infectious for about 4 days prior to the onset of their rash and fever. So, and as you know, it's a very, very infectious disease. So as far as a provider, when you're suspecting it, mask and isolate immediately. If you can get them if you're like in this facility, you probably can get them in an airborne infection isolation room. If not, a private room with a closed door. If you're in a more traditional clinic, call your local health department immediately, and they can help make sure that guide you through what specimens to collect and getting them through the public health lab system quickly so you can get results really quickly, because we will expedite them at various levels, especially if there's a high risk exposure that may have happened, whether for you all, if it's like an immunosuppressed population or a childcare, other things like that. So that when you send them to private labs, it is often very hard for us to get those specimens. And especially as pediatricians, we know how hard it is to get some of these specimens sometimes, and we don't want to bring them back into the healthcare setting if you don't need to get repeat specimens. So those are all really important. And actually, what should be on here is call your infection control. And I know my IT colleagues will appreciate that too. Call infection control immediately if you're suspecting measles, because you have to actually do a lot of other measures once, if that case is confirmed, as far as contact tracing and seeing who was even making sure that room is not used for the next couple of hours. So sort of as a transition to and shifting, I think more and more we have learned in public health and in medicine and healthcare, we have to kind of, especially in this information age where people are getting information differently, we're all just overwhelmed with information. How do you make the information more relatable and make it stick? So this is a great graphic, and there's a few different variations of this, but really trying to, again, answer families' questions about what is the risk of getting measles and what happens if you get measles versus getting the vaccine, because so many people don't even remember what measles is or what it looks like, and just have heard about it as a regular childhood disease. Not that, of every 10,000 people, 2,000 would be hospitalized, or that 500 of those would get pneumonia, and that 1,000, so 1 in 1,000 basically, will can potentially die or have permanent hearing loss. And then, of course, there's acute encephalitis. And then 16 of 10,000 people can get subacute sclerosing panencephalitis. And I'm going to talk briefly about that in a later slide as well. You can have a few with abnormal blood clotting as well. And then also something that I even sort of forgot about until we've started seeing more measles as well, but almost all cases have some immune amnesia as well. And the UK has really demonstrated some good data about literally having more antibiotic use, more infections for the kids that had measles versus not, after big outbreaks they've seen, versus the risks of the vaccine. So I think as you're talking to your patients, of course, first of all, just asking them what is their biggest concern. But I know we often are not talking as much about the balance of getting the disease versus having the vaccine, and with a lot of concerns that have been elevated and circulating unfounded claims about the risks of the vaccine. And this is just a nice sort of cartoon about getting amnesia from measles. Seattle and King County Public Health, I think, partnered with an artist to put this together, but just, again, reminding people that getting measles is not just getting the measles, but also that you are now becoming more susceptible to other infections as well, immune amnesia, and what does that mean exactly? And just again to punctuate, because this is another thing I think the general public doesn't know. And again, those of you who haven't really seen measles cases because of vaccines, or as much SSPE, if you look again, that last time I mentioned that we had a huge outbreaks in the late 80s, early 90s, 1 in 1,300 or so children less than 5 years of age got SSPE later, and 1 in 609 for infants who got measles when they were infants. And of course, they're more susceptible to getting measles as infants, and they're then more susceptible to get SSPE later. We've had 2 diagnoses in 2025 from California that were from prior measles cases. And then in some places like the Republic of Georgia, they've had an even higher incidence of SSPE. So this can take up to 35 years later at the outset. Oops, sorry, I keep hitting that. But the median is 12 years. So it can be many, many, many years later. And the diagnosis, well, and I think this is talking about the distinction between diagnosis takes a while sometimes too to figure out what exactly is happening. And definitively, it often isn't until you get pathology post-mortem. But the latency period can again range anywhere from 2.5 to 34 years. And then there's a really great, if you didn't see it, the New York Times had a really nice piece from this mother who had a baby who was infected with measles during some huge outbreaks in the UK in the, I think, 2010s. And then later, much later, developed SSPE. So it's just a really good story. I think we're also learning as far as communication. How do you tell people sort of the numbers, but often the numbers aren't resonating as much as the stories. So just wanted to give you a little more tools with that as well. Um, and then the other thing I think I'm trying to make sure we do in public health more is talk about impacts of when you start to decimate public health, or, for example, decrease confidence in vaccines. If we had, there was a modeling study out of, I think this one's from Yale, but then the Common Health Coalition and some others put some nice graphics together. They're projecting that we could see a 5% reduction in MMR vaccine coverage over the next 5 years. And it's already been close to a 0.8% decrease in the nation for the preceding years. So it's a pretty decent potential estimate given what's happening with the confusion around vaccines and the recommendations. So we could get to well below herd immunity nationally. And their estimates on this and modeling with that would we have a 7 times increase in illness. And so you can see here how many more cases we would see, over 4,000 hospitalizations and 36 deaths. And then in public health, we're not doing enough of this, but what are the expenses of that too? Like, what does that cost healthcare? What does it cost? So direct healthcare and treatment, over $40 million. And then public health response costs, almost $1 billion. And then also really trying to do some estimates of productivity in this work. Because again, trying to resonate with families and people in the general community on how it impacts them, and really thinking about productivity in this work. So just some nice visuals and graphics and just messages that I want us to do more from public health as well, and for clinicians like you, and you're communicating to others about the importance of vaccines and what are the downsides if we don't vaccinate our populations. Okay, so now I'm going to move to partnerships. Was really exciting. I would say, so I stepped into, as mentioned, I stepped into this position in February of last year, and I knew there was a change of administration, and I think they had already, I can't remember actually at what point, someone else probably does, when we knew that there would be a new secretary who was very anti-vaccine. I actually remember RFK coming to testify against one of Senator Pan's bills in Sacramento. So a long-standing anti-vaccine person who, and then in August, I already mentioned, there was the firing of the CDC director, and then 4 other high-level people of the CDC resigned as well, just given what was happening there. And so I think public health was feeling really, really overwhelmed. I've never felt like my entire field was under attack so much as, I still do, but in California, we are really excited. We've been able to do something about it. So in December, we were able to announce the Public Health Network Information Exchange. And we've been able to do a few different pillars related to this. So we brought on Dr. Menares, and she's helping us really think about innovation, which I'll talk a little bit more in a bit. And then Dr. Deb Howery was the chief medical officer and the right-hand person of the CDC director. And she'd been there for many years already at the CDC, and really as the chief medical officer, sort of the high-level subject matter expert across the different divisions and centers to help make decisions. She resigned, but she's helping us with a lot of our global and regional and national collaborations. And then how many of you, does anyone subscribe to or know of your local epidemiologist or YLE? A couple small hands, yeah. It's my ID or public health colleague. The rest of you should sign up too. So Caitlin Gentilina is, she's the woman who is in the top middle there too, but she's your local epidemiologist. She's got a national footprint, but she's based in San Diego as well. So she's our communications arm. So the governor and Secretary Johnson and I welcomed them as our way to try to rise out of the ashes. And I'm going to talk a little bit more about each of these endeavors. So again, innovation, we're really thinking about cross-sector innovation. How do we leverage this moment of advanced technology and funding frameworks? We've seen how fragile already our public health infrastructure and funding is, and how do we start to think about that in a more cross-sector way, and also in this moment where technology is accelerating exponentially and typically we are always behind. How do we not get even further behind? So that's sort of innovation. I'll speak a teeny bit more about that at the end too, and then a lot of strengthening partnerships and collaboration, and then communication. So, as far as collaboration, so all the different ways we have been stepping up and finding different partnerships. So, there are a couple different health alliances that we're part of that are intersecting. There's a larger Governors Public Health Alliance. I'll show you a map of who's in that in a moment. And then we also were the first state to join the World Health Organization's Global Outbreak Alert Response Network, as we were also worried about this withdrawal from the World Health Organization. And how we weren't sure, how much the CDC was going to be able to participate and get good information coming out of different countries. So we joined that also actually last September. It got a lot more publicity earlier this year. And they have these calls every Thursday that are like at 5 a.m. Pacific time, but we have some dedicated teams who are rotating to listen to those and get other kind of information out of that response network. And then the West Coast Health Alliance, which is actually now a subset of the Governor's Public Health Alliance, but I'll talk more about what we've been doing there too. And then I already mentioned how we updated our California laws. And then another huge partnership actually with colleagues of yours here at UCSF, Dr. Priya Shetty, who is in the Translational Institute, does some TB work with Devin as well, has been helping us co-lead a Public Health for All Californians Together coalition. So I'll talk a little bit about that too. So this Governor's Public Health Alliance is 15 states or 14 states in Guam, and it is geographically spread out. It is intended to be nonpartisan, although it admittedly is all Democratic-led states, but it's a coalition of governor-level agreement and groups that have come together to coordinate on health threat detection. We were also working with them a lot on how to best sort of work with the World Health Organization when the CDC withdrew and when the United States withdraws. They have a lot of sort of experts that have been in prior federal administrations and supporting technical health collaboration. They've done a lot of policy statements and advocacy around, especially vaccines, but other areas as well, exploring these cross-border data exchanges across states as we lose capacity at the CDC. And an important priority of theirs is supporting access to critical healthcare like vaccines. And then within that, and was more solidified earlier, was the West Coast Health Alliance, which I briefly mentioned before. So some of our scope is, again, responding to threats of public health policy and recommendations, really working within our subject matter experts at our state health level. So I mentioned for California, for example, Dr. Robert Schechter is a pediatrician, was on the ACIP, was fired, but he is our chief. So he and his team help us look at, okay, what is the AAP said, or what are the latest vaccine recommendations to be looking at? What is the data they're basing it on? So that we can feel comfortable as we look to other resources and sources for evidence-based methodologies to assess for what we will endorse and recommend in our state, especially now that, as I mentioned, when we passed AB 144, we need to actually post and say what is required. So we're partnering with our other states to make sure we're all aligned. And on that note, developing these unified recommendations and policy recommendations and guidance, knowing that within each of our states, implementing those may be different based on our local environments, our local statutes, and then continuing to hammer and all these different things. I think the overlapping theme is communications. We have to all think differently and work differently around communications. So we did last fall, the West Coast Health Alliance had a respiratory vaccine recommendations together. We have come out with statements when various links of Tylenol to autism, various other things like that, we've come forward with statements. And then what's really exciting is the RWJ Foundation has given us $1 million. We're funneling it through the Public Health Institute, and we convened actually in March here in San Francisco, 13 states total. So the 4 of us and other states in our region. And we are working together to think about a stronger, larger collaboration in the West. It's really led by health officials. We do very much work more closely with our governor's offices on the 4 state WCHA recommendations. And this broader collaboration is really health officials led. So we brought people together to think about what are some key priorities. I think some of the things that are coming out are, again, communications, listening better across our different states and coming back with information that lands with people for what they need, empowering people with good information. Continue to think about data exchanges, especially as we are seeing the loss of data federally and nationally that is transparent, and prevention and vaccines were sort of the third theme. So there's more to come on this, but this group has just hired a managing director that can actually focus on this. Many of us have been trying to do our regular day jobs and a lot of these new initiatives and projects. And so we are excited there is a new managing director. They're coming up with some summaries of a big project we can try to do across these states and really strengthen this collaboration so that regardless of what happens, I do hope that there is in the future a federal public health infrastructure that is stronger again, but we can still do better as a region, and also being able to bridge outside of government and do things a little bit more nimbly. So that's sort of the intent of what we've been working on with that larger. And it doesn't even have a name yet, but we're working for this 13 states to work on a collaboration. You may have also heard the Northeast has a public health collaborative that is not a governor-led, but health-led collaborative. And we are meeting with them frequently as well. There are some in the Midwest and elsewhere that are trying to figure out how to have more stronger regional collaborations. So again, we're all trying to stand up and do what we can. And now we just need to work on complementing each other and not duplicating efforts. And then here in the state of California, we have launched this Public Health for All Californians Together coalition. So the goals around this are, again, to improve build trust and strengthen partnerships. I think just over and over again, I'm going to keep saying, stronger together. And how do we build a network of networks, but really also work better across sectors? And I think public health and healthcare are often so separate. There's a national organization called the Common Health Coalition. Some of those measles cost slides I noted were developed by them, and they have done a national version of this, and we're very much in tune. And they're working actually also with YLE to do a lot of communications, a lot of explainers when policies change, and we're trying to do this here in California. So this is co-led by us at CDPH, CPR3, which is what Dr. Shetta's group here at UCSF. So they're one of the triangle, and then Covered California. Dr. Monica Soni and her team at Covered California is really representing public purchasers, but they actually came to us and said, we're seeing some decreases in vaccine coverage, especially in certain populations and certain groups. How do we work together to address that? And we're really trying to continue to gain other partners in this work to, again, make sure we cut through the noise and try to make sure people understand what is the evidence-based recommendation and what is it based on. And also really work again with this network of networks to get messages to people in the way that they want and need to receive them. And, I know I can only do so much in my role, and it's really like you all as direct providers or community leaders and faith leaders around different communities that can help. And then also as far as resources, how do you work with the private sector and foundations to bring resources together to bear? So there are three different active working groups. We have one that we may stand up if we need to, and we're poised to if we need to do something state specific for evidence and policy, especially with the strong academic connection. But we have a community partnerships group, a communications work group, and a data and implementation work group. To briefly mention the data and implementation, that's led by the CMO of Blue Shield and one of the others is from there's a consortium of community health, and CACHI is the acronym, but they've been really trying to look at bringing together not just data from our immunization registry, but from the health insurers about where are the vaccine hotspots of low coverage and how do we start to bring more resources to understand, is it access or is it confidence, or what are the combinations, and what are interventions that can really make a difference in those areas? And of course, as with everything data related, getting that data kind of aligned is always harder than we think it will be. So that's one example to talk through. And then for the communications work group, they have a few different objectives around developing some strategies and activities, and then disseminating and amplifying unified messaging across these different partners, and then upskilling communications across the state. So they've done a bunch of trainings with the Frameworks Institute. And then I'll talk in a little bit about social media monitoring that we do with YLE also. And they have just put together or are putting together, and we will disseminate soon, a back to school action plan as far as getting kids vaccinated before school starts, and really trying to do that earlier than usual because of this widespread confusion that's happening. So they've been looking at needs and insights in partnership with the Community Partnerships Group, who did focus groups throughout the state, and then working to develop and disseminate. Let's see, I'm going to speed through so we can get some questions, but there are some guiding principles here as far as this back to school action plan, and some links to resources, and then FAQ-based guides for parents and clinicians. And we'll make sure to get those to you. So this will be out very soon, will be spread throughout. On that prior slide is a QR code. So please do join our coalition if you are interested. And we've been having periodic webinars to kind of update people on what's happening. And then you start to get sort of information that we're funneling through to people. And then we're working with our partners within the coalition to really adapt the messaging for back to school to your unique audiences of those different partners. So that's what's happening with that. And then with communication, partnering, we're doing something called Project Stethoscope with your local epidemiologist. So really trying to use her team's expertise on social media monitoring. We have a little bit of limited ability to do that in the health department, but really listening to all different kinds of trends, whether it's, traditional social media, Reddit, looking at Google Trends and other things, and I'll show you an example, and then being able to do more targeted outreach and doing some pulse surveys just to hear, like, what are the things people are worried about related to health, or how are different messages landing, or, getting sort of re-upped and getting more viral, and creating content and communication tools based on the feedback loop. So having a better feedback loop. I think traditionally public health is very unidirectional. We do a press release and we do things one direction, and we don't often have a good way to get information back, especially in a state this big. And again, working together and also with the FACT Coalition to really try to formalize our community messenger network. Because again, I don't know how many of you in primary care, my husband actually, some of you may know from training here too, but he's at Kaiser San Leandro, and now he has families who, it's the third kid. He's been taking care of the whole family, but now the parents are saying, TikTok told me that I should wait on vaccines. And, he's like, but you vaccinated the other two. And so anyway, I see some heads nodding. So we need to figure out how to get out there and how to sort of counter what's out there with accurate information, evidence-based information. So this is a great partnership to really help us think differently about that and to formalize networks. And one quick example so we get these monthly reports with Project Stethoscope for California, and they looked at historical trends of when people are starting to do searches about what's required for school and back to school. And typically it happens more closer to school starting, but because of all the confusion and all the different recommendations that are coming out of the federal government, interest has started to peak already. So this is also why we're trying to get our guidance out even sooner as far as back to school, and really having clear, frequently asked questions on requirements and access to vaccines. Again, continuing to use non-clinical messengers as well, and just word choices. Like, instead of using the word mandate, that is really, I think we've seen a lot of different ways people are having PTSD from COVID, school immunization requirements instead of mandates. So just very important tools like that the words matter. And then very briefly on innovation, this is the sort of part that we are still working on that is, I think, the less fleshed out, but we're excited to try to launch an innovation institute where we work with a non-governmental institute and put together an advisory board with philanthropy, academia, members of our state government and the private sector to work on being a test bed for example, our first priority is healthcare data interoperability with public health, so we can have more timely trends, but have them done in a secure way, but figure out how to make a more sustainable model to do that. And again, not get left behind the way we always do with our usual structures and resources. So more to come on that, but we're wanting to improve our data infrastructure, use tools, especially trying to think about how to use AI effectively, and different funding frameworks now that we've been so threatened. And this was a convening we had in January with our team, also here in San Francisco. Just very exciting, and stay tuned for more on that one. Some acknowledgements. A lot of those immunization slides, especially in measles, were from Dr. Schechter, who I mentioned, other people in our comms team, and others who have contributed to the work or the slides. So with that, I will pause. And oh, and I didn't leave as much time for questions, sorry, but I will pause now.
Great to hear about all of the exciting work. Thinking about some lessons that we have learned from COVID. You will know that we recently had a case of measles in general. I was really impressed how well things swung into action from the infection control team and from the leadership in the clinic, and things were well contained. But it struck me as I listened to the providers talking with families on the phone whose family members may have been exposed. What we were asking is extraordinarily difficult. These are people for whom, day-to-day work and salary is essential so that they put food on the table. During COVID, we had structured in place so that we could deliver food boxes and other essential items. And given the risk of the if there is any discussion on the public health level, how we could support families rather than just relying on their motivation and altruism, but have some more.
Specifically for quarantining, if we're asking people to quarantine. Yeah.
Quarantine.
Can you briefly summarize the question?
Sure. So Dr. McNamara, nice to see you, was asking about with measles, and when you are asking a family to isolate and or quarantine, and especially for families that are really don't have the resources to not work and or, and this happens actually also with a lot of food handlers who might have to be restricted for weeks or months. Some of you have had this happen more with your patients that have, Shigella or salmonella that they're shedding for a long time. It is an important challenge, and I think there's some discussions, but it still feels like it's a ad hoc solutions rather than the longer term solutions. And to your point, during COVID, people rallied together, all hands were on deck to help people, whether it was creating hotel room availability at cost or and we're at such a challenging time right now where I keep saying to people, there are lessons learned about what we can do when we get resources, but all the resources have been taken away, and in fact now decimated even further. I felt like, wow, we can demonstrate what we can do in public health if you give us those resources. And I thought the one thing that might change the panic and neglect cycle for public health resources for exactly those kinds of things would be a once in a century pandemic. And instead, we're actually, being attacked. So I do think communications are part of that. And also, a lot of these cross-sector coalitions and work, I think, is also where we need to go. We can't rely on government to do all this anymore, especially when you see the kinds of cycles we are experiencing right now to not take care of each other. So it's a really important issue. I think a lot of local solutions have been local, but there is not a better kind of, infrastructure solution that has come through yet. But it's an important question.
It might be a good public-private or interfaith kind of collaboration. I hear you. I know you don't have resources to do it.
Yeah, I think. Hi, Naomi.
Hi. So I have a question more about the communication piece of it. There's, from my understanding, a lot of data that said that giving people data is actually not very effective. So a lot of the stuff that we presented is like, let us tell you the data. And so I feel like there's two pieces. One is that it tends to be an identity issue. So people are like, I'm a vaccinator, you're attacking my, if you're trying to push them to get a vaccine. So that's one piece. How do you guys kind of feel about that? And then the other part is like, it's just the airwaves is like autism and MMR, and just people hearing it a million times and making them believe it, even if they don't like actually believe it. And so how do you sort of like undo that? And should we be flooding the airwaves like, this is what MMR causes, and then focus on that, and actually it's really small, Like, I don't know, like, how do you guys think about like countering those things?
Yeah. So let's see. So as far as data versus, even when I had a really great talk from, it was sort of a legislative advocate person. They talked about as far as convincing policymakers, but I think it's true for individuals in the public too. It's really hearts and minds, right? So the mind part is the data and trying to get the facts straight, but the heart is the stories, or most importantly, probably is what are you worried about? What is your parent, of your patient worried about, and or your neighbor who is, staunchly anti whatever it is, trying to get curious and ask them what their concerns are and then trying to address them. So I think that's easier said than done. And I think it does have to be both and there are so many scientists and physicians, honestly, right? And public health epidemiologists who do not communicate well. They just a lot of jargon, a lot of technical words, and we do just need to work, which is again, I think the partnerships is where we can get there. If you can find sort of champions who can bridge and help, translate, it really is translation in a different way. And then to your other question, and flooding the zone, we have not effectively done that. And clearly, I need to find a better word for the other side because I don't want it to be an othering. Everybody, we all want our families and communities and kids to be healthy. But there has been a flooding with, unfounded rumors. And here's one just wording choice. Apparently, misinformation and disinformation are now like falling on deaf ears too. So you need to say things like unfounded claims or rumors, or but not using words like misinformation. So I think the words do really matter, and doing more communications training, for all like medical professionals, public health professionals, research scientists. I think we all need to communicate better. And I do think for me personally, if I think about talking to individual patients versus like trying to explain a report, I think that's where I personally feel like I've learned so much and why I miss it so much too. But so I think a lot of you who are still on the front lines are learning a lot too about what are your patients worried about and help. But then we do have to figure out how to amplify and how to use the current environment to amplify in a way that I don't think, pediatricians, public health have figured out how to do effectively yet. I think we're making strides, but we have a long way to go to actually catch up, I think.
Hi, I'm Matthew Kahn. I'm a pediatric immunologist. I really want to follow up on Naomi's question because I think about, so I'm a parent of young kids, and I get tons of social media, just as an example, about language that I use with my children. That like if you say something a certain way, that they feel a certain way, that a 3-year-old will process this in a different way, and there's kinder or different ways to say this, right? And I think that type of practical coaching is going to be really important because I'll give you 2 examples that I saw yesterday in the immunology clinic that are at the extreme ends. And this is how much code switching or like emotional switching I'm doing, right? So there's one family, they are very worried about their child getting recurrent infections, but they're not going to vaccinate until they're school age. So they're not going to not vax, but they're going to wait for 5 whole years, no vax. Another patient who's immunocompromised, mom wants to know when can I give MMR at 6 months because I'm so worried about measles. So those are like what I'm swinging through. And I think if we can have examples of how to have these conversations where like, if you have it a certain way, you see tension, where, if you have examples of like someone who has some example language where it's at least productive, you're not gonna make that person who doesn't want to vax for 5 years, do it in one conversation, but at least to open that relationship. I think those are the kind of practical things that you can give someone in 30-second sound bites that would be really helpful for pediatricians.
Yeah, and to recap, sorry, I forgot to repeat the other question. I think the question is, are there tools or resources that frontline clinicians like yourselves can quickly adapt to, like have that 30-second conversation that won't push people in the wrong direction? Is that sort of yeah. And I do think more and more tools are there. AAP is actually doing a great job. And the other way, you said you are on social media. I think I actually see a lot of great tools on social media. So we'll make sure, I forgot to add a lot of links and resources here, but AAP is doing a great job. There's some unbiased science and collective evidence collectives that are trying to do a lot of that. But the AP has some toolkits too, and like it's directly for pediatricians on like just some of the tools you're talking about, like how to frame a conversation, or, you know, this word does land better than this word. And again, I think it's back to being curious rather than presuming. I mean, you actually, well, but yeah, asking like, so why do you want this? Or what is your concern? And I think sometimes when we're in a hurry, we don't have time to do that too. But there are tools. And then this other Frameworks Institute that we've done some training with the coalition as well, and trying to reach more and more clinicians, also has a lot of those kinds of tools. So those are some resources off the top of my head.
We're over time, but thank you so much.